have additional human resources put in place on the transformation team to help assist with the implementation of these 32 recommendations. That includes a dedicated project manager, a team to oversee the implementation beginning this fall. We are also putting, as I mentioned, the additional resources in place as part of the transformation team for the Provincial Health Authority. It's important to note that some of these 32 recommendations have already been implemented. For example, the task force recommended exploring the use of personal care homes to accommodate short stay for patients. Our new program supports patients so that they can stay close to the hospital instead of in the hospital to receive the rehab care that they need after surgery. Moving patients to available beds in personal care homes makes acute care beds available for someone else who needs the medical care. The recommendations in the report are part of a series of new and ongoing activities that we built on what we have accomplished so far. They will complement other initiatives that will help us expand our reach further into improving access to health care. They include expanding the traveling orthopedic team to Carbonear this September, working with ophthalmologists to find solutions to complete more cataract surgeries, better use of operating rooms at the Janeway and St. Clair's to help ensure surgeries are completed, expanding orthopedic surgeries in Gander with the reduced hospital stay for patients, exploring same-day surgery options in Western, and taking ambulatory care and urgent care services out of the health sciences and moving them into the community so that people waiting for care do not have to be bumped behind people with more pressing emergencies. We are also working with the Provincial Health Authority to complete a demonstration project to assess the model of community-based adult programs. Adult day programs provide support for older adults who live at home. They provide an out-of-home respite, non-residential option that provides meaningful occupation and support for activities of daily living. The program is intended for adults who require support and supervision due to cognitive and/or physical issues. It endorses a home-first philosophy to support individuals to remain in their homes and communities while accessing supports and services to address their needs. All of our initiatives, combined with our recruitment activities that are bringing more people into the province, will lead to a better healthcare system for Newfoundland and Labrador. In closing, we are thankful to the members of the task force for volunteering their time to develop this report, and will now turn it over to Cassie to discuss the report in more detail.
Thank you, Minister. My name is Cassie Chisholm. I am Vice President Transformation Health Systems with Newfoundland and Labrador Health Services, and I'm the primary lead for most of the recommendations in this report. On behalf of Newfoundland and Labrador Health Services, I would like to thank the members of the task force for the work and the time that they have contributed to this report. And I would also like to thank them for the commitment that they have shown to continue meeting to address the medium and long-term recommendations. As surgical demand grows, the detailed assessment of causes and actionable recommendations is very welcome. Newfoundland and Labrador Health Services looks forward to working with government to implement all 32 of the recommendations. Some of these recommendations, like the 4 related to maximizing our workforce, are very familiar. We know that staffing is a global challenge, and Newfoundland and Labrador Health Services has been working hand in hand with government to recruit qualified professionals. Going forward, we will work to ensure there is a reasonable cancellation policy for fee-for-service specialists. We will also establish and maintain a list of nursing and allied health professionals who are interested in overtime and additional shifts. And we will work to increase the number of staff to enable our capacity. We will also increase the exposure nursing students have on surgical wards. Within the next 6 months, we plan to have the bulk of the Surgical Task Force recommendations complete. We're currently working with the department to subsidize sleep apnea assessments and, as Minister Osborne mentioned, to open up another operating room at the Janeway to increase our capacity. By spring 2024, we should have a centralized surgical wait list for Newfoundland and Labrador. We should also have a centralized list of operating rooms and operative resources for the province. We will have launched a centralized single-entry intake model for people who require high-volume surgeries like total hips and total knee joint replacements or cataracts. We will also have policies for pre-admission assessments and standardized data collection across all 5 health zones. These short-term actions will allow us to ensure that no operating room stands empty while patients are out waiting for surgery. They will also provide a solid foundation for the medium and long-term actions that we need to take to reduce surgical backlog and ensure that our system can sustainably keep wait lists at or below our national benchmarks. There is more work to be done to ensure that you have the health system you deserve, and these recommendations will guide us in that work. I look forward to checking them off as completed, and I'll now turn it over to Dr. Parfrey.
Hello, everybody. Thanks, Minister and Cassie. As you'd probably know, the recommendations or the calls to action of the Health Accord have transitioned into the government plans, and I'm involved in trying to influence how these plans are actually implemented. So one of the major pieces of the Health Accord was around the transformation of acute care hospitals, and in particular taking a provincial approach to solutions so that the same degree of quality and expertise was available to every resident of the province. And in this situation here, the advent of a provincial health authority has facilitated the development of a surgery network that integrates all the surgery units across the province and allows solutions that have been recommended by this particular task force. The second thing is that there was a very large focus from the Health Accord on quality, which is multiple domains. One of the ones that we kind of tend to think about, not to think about, but which is integral, is that one of those domains is around access, and in particularly it's around timeliness of access. And again, you can see here from these task force recommendations that the people who wrote it wanted to have a central intake or a single entry intake, and the data arriving from that tells us about the amount of time people have to wait for their procedures. So that is a particular focus on quality, which is important to us. And then the third piece of this, in terms of its consistency with the government's plans, and is all around what we call a learning, health and social system. And by that I mean is using evidence to determine what our current practice is and then changing to get best practice. And as you can see here from the recommendations of the task force, they want to know what current practice is and consequently then innovate and change and develop processes and change management processes to get better practice. So I'm going to take an example of the hip and knee joint replacements to explain what I'm thinking about or what we're talking about. So joint replacements is a national priority because so many people need joint replacements, and there is a recommended benchmark for achievement of to determine the rate of achievement of those particular benchmarks. They're available across the provinces, all the provinces. They're available to us. So we're anchoring our efforts in improving joint replacements on those particular metrics. And the task force demanding that we get those wait times and then innovate as a consequence. So we know as a consequence of COVID and the growing aging population that the need for joint replacements has gone way up. And we know as a consequence of COVID that our replacement number is now 3,000. So and we know the wait times that those 3,000 people are exposed to, and they're not meeting national standards. But what's attractive about the surgery task force is that they've come up with innovative ways of being able to increase the number of joint replacements within the system that we've currently got. So we have same-day surgeries taking place in St. Clair's, new, adding it to Gander, adding it to Corner Brook. That'll add hundreds of people who've had a joint replacement in the coming year. We have a focus on trying to improve the efficiency and the utilisation of operating rooms in the city. That will lead to hundreds more joint replacements. And then we have what I think is an innovative solution is take the joint replacements out of the city of St. John's, bring them to Carbonear, bring them to St. Anthony, and bring the care to the people. And again, that fits very much with the logic of the health accord and the plans that the government have. And all those initiatives are feasible in the current system and will actually have a big effect. But where we will have to get even more innovative and create more resources is to bring down that wait list to a more reasonable number of people. So I'm just probably in effect saying that it's a high priority area, joint replacements for the provincial government, but it's equally high for the national government. So I think that the take home messages are that in developing a learning, health and social system, which is what this is all about, using data to change actual practice into best practice, try and keep care as close to home as is possible, and use evidence to make decisions, this particular task force has taken all those into consideration.
Well, thank you, Pat, and we'll open it up for questions for any of the media.
You mentioned better use of the operating rooms at the Janeway and St. Clair's. Can you explain what you mean by better use of the operating rooms?
Well, we're looking at creating a 6th operating room at the Janeway site, which will provide more surgical time and allow for additional surgeries. I'll pass it over to Cassie. It's more of an operational issue, so Cassie can expand on that.
Yes, so we do have some opportunity to reconfigure the types of surgeries that we currently do at St. Clair's and at the Janeway so that surgeries around children and women's health are happening at the Janeway, which is the natural place for those surgeries to happen. And more orthopedic surgeries then can take place at St. Clair's, which is a place where we're already doing orthopedic surgery. So it's really just moving around some of the capacity that exists right now and opening up a little extra and replacing surgeries in a different space.
So are there surgeries happening at the Janeway that aren't women and children right now?
Not typically, no. No.
Does the surgical backlog affect children?
It affects everybody. It's one of the reasons, so let's be clear, there's been a surgical backlog in Newfoundland and Labrador for decades and decades, no different than any other jurisdiction in Canada. It's been exacerbated by the pandemic, where there were less referrals for surgery during the pandemic, less surgeries happening. We've got an aging population. We had the cyber attack, which also created pressures on the backlog. So looking at the pressures and the fact that, not only the stars all aligned, we have an aging population, more referrals because there were fewer during the pandemic, so the wait list was growing. How do we deal with that? The Surgical Backlog Task Force was put in place to look at that. We are leaders in the country in terms of looking at solutions on how we reduce that with an aging population. And those 32 recommendations will help individuals through all age groups in the province, including juvenile surgeries.
The NLMA, immediately after this, is holding a news conference. What was their level of input into all of this?
So the NLMA were involved in the task force. They had somebody sit as part of the task force in designing these recommendations as well. We had health professionals, bureaucrats from within government, with Yvette Coffey, for example, sat on the surgical task force. So people with a professional experience in why we have the surgical backlogs and how we can address the surgical backlogs. You know, I guess just to encapsulate, we need a central intake system for individuals. We now have one provincial health authority. We no longer have 4 silos in the province. It's one provincial health authority. So we're going to have a central intake system. We are going to monitor the availability of operating room capacity or surgical capacity throughout the province, so we can better match those who are on the wait list with capacity that's available. You may get a procedure done in one area of the province, or such as the traveling orthopedic surgeons, we bring the surgeons to an area of the province where surgical or operating room capacity exists, and we match the surgeons with that capacity, or we match patients with capacity that exists. Better management of bed processes, better discharge. We're looking at working with the personal care home sector, and we've had several meetings with them. Just a heads up, we'll have an announcement with them in the very near future on improvements in that sector. But we're working with them to better utilize some of the beds so that we can get people out of acute care beds and into personal care beds, creating additional capacity within the acute care system, allowing for surgeries to happen because people have a bed to go to. We're looking at, you know, in addition to the single entry model, monitoring the operating room procedures, the wait times, the availability throughout the province, having a standardized list. Right now and prior to the coming together of the Provincial Health Authority, things were measured in different ways in different regions of the province. So having a standardized process will also help. Having a list of health professionals that are ready, willing, and able to provide additional hours of work or overtime hours, so that it makes it easier for the system to reach out to those who are willing to do so. All of these things are part of the recommendations that are here. Recruitment, which we had an announcement last week on progress we're making with recruitment. We absolutely need recruitment, but we can also better manage the health professionals we have in the system by ensuring that we don't have cancellations, either due to the or lack of availability of healthcare professionals, or lack of availability of a bed, or ensuring that people are not missing appointments. The system we're putting in place to remind individuals so that they don't miss an appointment. All of these things are pieces of the puzzle that I keep referring to, that when you put them all together, the traveling orthopedic surgeons, the Heart Force One, which helps people get back to their communities faster, freeing up acute care beds in St. John's. All of the things that we're doing fit into the larger picture that was developed by the Health Accord. The health information system will help with the monitoring and the standardization of processes and the measurement of wait times and better organizing surgical capacity in the province. So it all fits together to improve the healthcare system in the future.
I'd like to specifically address personal care and long-term care homes. I know you just talked about it. You know, the problem obviously with underused beds in those facilities is that there's no staff to attend to the people that would be in those beds. And I know you said there will be an announcement soon, but this is a problem that has existed for years, and there are long wait lists for people to get into these facilities. And now you're planning on putting the people that are waiting for them in those beds. I'm just curious how exactly that will look in reality, where this has been a problem for years.
So we've just opened up additional beds in long-term care in the metro region, 50 additional beds about a month or so ago. We've opened up additional beds at some of the long-term care facilities by better scheduling and better management. Recruitment of healthcare professionals will help us open up additional long-term care beds within the personal care home sector. I don't want to get into announcing what's going to come in an announcement in the very near future with that sector, but we've been working with that sector to look at lower acuity level 3 that were never able to be admitted to a personal care home. One of the recommendations in here is to look at that. We've been working with the sector on how we can make that happen. We have the day program where that's now in use. We have a program that is currently employed in a number of personal care homes that we started off as a pilot program just a few months ago. It's been working well, where we can have individuals go into a personal care home once they come out of acute care, but they not ready to go home, need some additional assistance. So we're working with the personal care home to expand. There's about a 30% vacancy. If we're looking at lower acuity level 3, for example, we can fill some of that capacity in the personal care homes, taking the pressure off of long-term care, but also taking it off of the acute care beds and provide the alternative level of care in the personal care home as opposed to in a hospital bed. So those are things that we're working on with the personal care home sector. And again, we'll have more to say on that in the very near future.
Can I just add one comment? The access to the personal care homes is not a big issue. It's the access to the long-term care facilities that's the problem.
We learned in the tech briefing that there's a number can't really be attributed to the size of the backlog. So I guess without using numbers, how would you describe how big the backlog is right now?
I'm going to ask Cassie to answer that, but a number of the recommendations in the report talk about standardizing how we measure. That hasn't been the case throughout the province. So now that we are one provincial health authority, we can standardize how we measure surgical wait times, how we standardize the expected length of stay, post-operation, the central intake, for example, how we pre-surgery, how we measure the time somebody is actually waiting, and standardize that throughout the province. And I didn't mean to steal your thunder, Cassie, so.
No, not at all. To use words, not numbers, for the size of the backlog, it's large. If you take the two largest categories within the backlog, total hips and total knees, joint replacements, the estimate would be around 3,000 people waiting. Another large category would be cataracts, probably about 4,000 cataracts on that list. But as Minister said, our processes for measuring these things and documenting how many are waiting and who's active on a list, who's inactive on a list, all those sorts of pieces to the complexity here, they were done differently across the 4 different health authorities prior to Newfoundland and Labrador Health Services. So part of the work ahead of us now is to standardize and unify all those processes. And that's what we mean when we say a single entry centralized surgical wait list. And we're really looking forward to being in a place where we can give you a bit more accuracy on that number.
How quickly do you hope to be able to start chopping through that wait list once all these recommendations are implemented?
We've already started. Yeah, so the initiatives that Minister has detailed already, for example, the same-day joints at St. Clair's and the work that we're doing in central Newfoundland and Western and Labrador and in St. Anthony, those are already starting to take a chunk. It's going to take some time, there's no doubt about it, but this report is being released today, but we've already started the work.
I think an important, sorry, Henrika, no, just to add to that answer as well. There are short, medium, and long-term goals in terms of the 32 recommendations. So some of the shorter term, as Cassie has indicated, we're already doing some of the shorter term goals. The medium and longer term, we have a dedicated individual now who their sole total responsibility will be the implementation of these 32 recommendations, so that 2 years or 3 years from now, somebody doesn't look at us and say, well, what happened to the 32 recommendations? So we are putting an individual in place whose sole focus will be the implementation of these 32 recommendations. In addition to that, the health transformation team put in place as a result of the health accord will also have dedicated resources that will have a focus on how we reduce the surgical wait list and the implementation of these 32 recommendations. So the process has started to look at the surgical wait times. It is complex because we do have an aging population and we do have more referrals as a result of the fewer referrals during the pandemic. All of these things, without the traveling orthopedic surgeons and without Heart Force One and without the same day, we would be in worse shape today. So we are seeing the results of what we're putting in place, adding to a very complex time in history because of the pandemic and an aging population. But as these recommendations are implemented and as we standardize processes of management of beds, standardized processes of measurement of wait times, pre-admission clinics, once people are done their surgery and if they're able to get into the community faster, whether that's the home first model, a personal care home, or long-term care, by creating additional opportunity in the personal care homes, we take pressure off of long-term care so that the individuals that are more appropriately placed in long-term care have a shorter wait because they're going, the folks that can go to a personal care home can. All of these things will help in reducing the surgical backlog. And the work of Dr. Martin and the group that have looked at this will, Dr. Martin has indicated that he and other members of the team will be available as we're working through these recommendations to continue working with government and continue working with the Provincial Health Authority to ensure that we are doing everything we can to reduce the surgical backlog.
I'd just like to add one comment to it. I think that the innovations that will occur to increase the number of joint replacements will be such that the number performed will be higher than the number referred and the wait list will come down. But the wait list, for it to come down to a much lower level, will require new capacity. And that new capacity is envisaged by the new St. Clair's Hospital.
You mentioned that there's going to be dedicated.
I think you got cut off, but then answer your question.
Yeah, sorry, no. Correct me if I'm wrong. I believe I jotted down that you said that the bulk of the 32 recommendations will be complete within the next 6 months. Is that correct if you said that?
I think, I'm not sure it would be fair to say the bulk will be completed within the next 6 months. They'll certainly all be underway within the next 6 months, but as Minister said, there are medium and longer term things that will take much longer length of time than 6 months.
Do you have a time frame in mind for when you want all of them to be completed, even the long-term ones?
That's difficult to answer, but I will say that over the course of the next 2 years, we do anticipate all of these recommendations as the health authority, is coming together as one provincial health authority. Some of these recommendations, for example, depend on the health information system that we've already put to tender, but being put in place so that we can standardize measurement and centralize intake. Some of the recommendations depend on the health information system, but all of the things that we need to be put in place to get at the 32 recommendations, we are starting. They're either in process or planned to start. But the reason we're putting a dedicated resource in place is so that we waste no time in achieving the 32 recommendations.
I would just like to add as well, the idea that some of these interventions will ever be completed is probably not a reasonable thought. The whole idea around what happens in hospitals around alternate level of care, where people are in hospital because they've got various types of disability, that's unrelated to their acute care, is dependent on community care, home first policies around long-term care, they are going to be, they will continue to be an issue while his health system evolves. So we have to be constantly trying to improve those areas.
All right, last question?
I have to choose one. You mentioned that there's this dedicated team. I know like the task force had all kinds of different professionals that work in the healthcare system making the recommendations, but what sorts of professionals will be looking at ways to implement the recommendations?
You're on the spot.
Cassie, do you want me to go ahead or do you want to go ahead?
You start us off.
So you're, in terms of implementing the surgical task force, I think that the surgery network is the basis on which change will occur. And the change will occur based on trying to innovate and change manage. So the change management around how you use operating rooms, how you use wait lists, how you've got central intake, all that stuff needs to take place. And then the subsequent improvement in matching actual practice with best practice, it will require a different set of skills. It will require evaluation skills, using data and using data to be able to translate knowledge to the various people involved in delivering care. They're transformation skills that are not really that common in a healthcare system, but they are going to be critical to change, manage the system, to be able to respond to need and to have a higher quality system. So I think that the transformation team that will be responsible to the two VPs need people with those skills rather than the traditional management skills that happen when you're delivering care itself.
You know, change is a job. It's hard, and it requires a skill set, and it requires expertise and capacity. And when we think across the system right now, the types of people you're familiar with in healthcare, there's a lot of clinicians, and those clinicians have jobs. Typically, it's things like doing operations and looking after people in hospital beds and those sorts of things. So I think it's pretty, you know, it comes to us naturally that we will have to look for people who have expertise to come and guide us through some of this change. We need the expertise of the people who are in the system to help us understand what the change needs to be, but we also need those people to do the work that we hired them to do in the first place. So right now, as Pat described, we're looking across, you know, for example, the Surgery Strategic Health Network. We're looking at the 32 recommendations in the Surgical Backlog Task Force report, and we're saying, what sorts of skill sets do we need to achieve these recommendations? And I think Dr. Parfrey has already listed out, you know, a bunch of the specific ones that we know of, not least of which is a project manager to keep us on the straight and narrow as we get this done. So I think what we're going to end up with is a mix of people who are clinicians, most definitely, but also process improvement individuals, people who are versed in implementation, data analysis, policy and planning. So you can expect to see a group of people like that very active in this space.
Thank you, everybody.
Thank you.
Socialized and learning health and social system.